Okay, so today we are going to discuss the post-operative fluid management. A 48-year-old lady presented um, by persistent hypertension and tachycardia post-operatively. Post-operative to THR Hartmann's procedure. Okay, so transferred to the ward at 3 p.m. and hypertensive and tachycardia. BP is 70/30 at 2 a.m. Fluid chat 2 times 250 ml bolus with small improvement initially. System 2. You are called to surgical HDO to review a 60-year-old man who underwent anterior abdominal perineal dissection for rectum under GA, for rectum CA under GA 12 hours ago. The nursing staff are concerned about the urine output. Physical examination is unremarkable. The examiner will give you a fluid balance chart and a news chart. Okay, so explain the chart. Fluid chart. What is the cause of low urine output? Persistent hypertension and tachycardia with two fluid challenges and nothing in between. The patient has reduced intravascular volume, may be due to inadequate fluid replacement in the perioperative fluid period. Is that adequate? No. How would you manage this case? In view of the response to previous fluid challenges, I will do more fluid challenges, 250 ml bolus or 10 ml per kg, and monitor the response, because it looks like hypovolemia, because it was initially there was a response. So I will do further two more challenges. Why would you give fluid challenge rather than speeding up the drip? Because fluid challenge is both diagnostic and therapeutic. Giving fluid slowly does not stretch the left ventricular starling law. Okay, so speeding the drip up does not give information regarding the patient's serious response and may not resuscitate the patient quickly. But if you give him a bolus, it will stretch enough the left ventricle, and so it will increase further the contraction. So Starling law is basically a law which says that like the initial stretch of the cardiac muscles is directly proportional to the further contraction. So if you give him like sudden bolus to the intravascular volume, so it will stretch the left ventricle, and so it will further increase the contractility. So that is why just increasing the speed of the drip will not help. Only the bolus can help. What is the formula of fluid challenge? So 250 ml bolus or 10 to 20 ml per kg, and monitor the fluid responsiveness. Okay, so the patient is on 2 hours monitoring. Is that adequate? No, he should be monitored hourly. Okay, so this fluid challenge. Okay, so this is this is 250 ml bolus or 500 ml in 30 minutes or 15 minutes. Sorry, 250 ml in 15 minutes. Okay, let me explain it again. So 250 ml 250 ml in 15 minutes, and 500 ml in 30 minutes. This is called fluid challenge, or you can say 10 to 20 ml per kg and monitor fluid. How to manage this patient after fluid challenge for the remainder of your shift? So regular review of the clinical signs, for example, like pill refill time, the urine output, BP and pulse. Repeat fluid challenge if necessary. Maintain high index of suspicion for other problems such as occult hemorrhage, and give instruction for nursing staff. You contact me if they are concerned. Assuming the patient become more hemodynamically unstable and you have given him more fluid, how to assess the cardiovascular function and the patient respond to therapy? Minimally invasive cardiovascular monitoring, arterial line. So I will pass the arterial line, lithium dilution cardiac output monitoring. Okay, lithium dilution cardiac output monitoring, and the pulse control analysis PICCO by central line, transesophageal Doppler in sleep patient, and CP monitoring less frequently. Okay, home to notify when. I will notify my consultant when no response to multiple fluid syringes 4 times maximum. How is blood pressure calculated? Blood pressure is the product of the cardiac output and the systemic muscular resistance SVR. The cardiac output is the product of the heart rate and stroke volume. How to increase blood pressure? Inotropic support and fluid to increase cardiac output, vasopressor agents to increase systemic muscular resistance. So increasing this and increasing this is equal to BP. So BP is equal to cardiac output multiplied by SVR. Okay. So you give inotropic support, inotropes, and fluids to increase the cardiac output, and vasopressors agents to increase the SVR. Hormone response to surgery and trauma. What hormone will be secreted to preserve circulation? So in trauma, these hormone TSH, LH, and FSH, these does not increase or change, neither decrease nor increase. TSH, LH, and FSH decreased are insulin, testosterone, and estrogen. These decrease in trauma or in stress conditions, and increased growth hormone, cortisol, renin, ACTH, aldosterone, prolactin, ADH, and glucagon. These increase in a stress situation. Where is ADH vasopressin produced, and what factors stimulate its secretion? Produced in the hypothalamus, when then transported, stored, and released from the posterior pituitary. Factor stimulating its secretion is reduced circulating volume and increased plasma osmolarity, angiotensin 2, and hypernatremia. Where in the kidney does ADH act? So they act in collecting tubules, collecting duct or collecting tubules. What is the action of ADH? Increase the reabsorption of solute-free water by the collecting duct. Solute-free water, remember. Initial reabsorption by the thick ascending limb of Henle. Thus increase the concentration of the interstitium. But this is not the function of ADH. ADH only reabsorbs the free water from the collecting tubules or collecting ducts, and also have a mild effect on the vasoconstriction of the vessel. So here NaCl is reabsorbed here in the thick ascending limb. NaCl reabsorption by the thick ascending limb of Henle thus increases the concentration of the interstitium. So this interstitium concentration will increase, and around the loop of Henle here, and this enhances the nephron's ability to reabsorb water, from the tubules, so they will catch H2O. So there is a very beautiful mechanism we will study now. So here you can see this is countercurrent multiplier mechanism. So what is the process by which the medullary tissue becomes so hypertonic? What are the mechanisms by which the kidneys increase osmolarity in the renal medulla? So you can see here the descending limb of the okay, so this is the descending limb. This one. So the descending limb of the loop of Henle is permeable to water but impermeable to solutes. Thus water moves across the tubular wall into the medullary. So you can see here H2O. So all the H2O goes out from this tubule because these are permeable to water and impermeable to solutes. So they will go out into this medullary space, okay, making the filtrate hypertonic. So the filtrate here will be hypertonic, okay. Sodium is actively transported out of the thick ascending limb, which is impermeable to water. Now sodium from here, you can see here, sodium from this thick limb will be transported outside actively, but this is impermeable to water. This creates an osmotic pressure, so it will create here osmotic pressure here, drawing water from the descending limb into the hyperosmotic medullary space, making the filtrate hypertonic. So what will happen that when this place is hypertonic, so they will draw water from the descending limb, as you can see here. So these go side by side, and okay, now the counter current flow within the descending limb and the ascending limb thus increases or multiplies the osmotic gradient between the tubular fluid and the interstitial space. It is an efficient way of concentrating the urine over a relatively short distance along the nephron with minimal energy expenditure. So this process continues. So here it continuously transport. You can see here sodium and chloride, sodium potassium, sodium potassium, or sodium chloride and potassium pump is here. So they constantly transport sodium chloride out of this thick ascending limb. What will they? This will increase the osmolality of this interstitium, or this outside portion. So they will constantly take water from it, or due to osmotic pressure they will catch water from the thick descending limb. So this continuously helps in concentration of the urine, and this is called counter current multiplier mechanism. Okay, now we will go back to these own questions. So they have discussed actually this thing here. So by what mechanism does ADH facilitate reuptake of water from the tubular fluid? It stimulates water absorption by insertion of aquaporins, channels, protein channels, or water channels into the membrane of the collecting ducts. This channel transport to solute free water through the tubular cells and back into the blood. So what happens actually, this is the collecting ducts. So they vasopressin or ADH inserts aquaporins in this membrane, and so they will reabsorb free water into the interstitium and into the blood vessels. Why does the water cross from the tubular fluid into the medulla? Because of the high osmotic gradient between the tubular fluid and the medullary tissues, and this is by the thick ascending limb. High osmotic gradient or high osmotic difference. So here you can see ADH, or arginine antidiuretic hormone, or arginine reduction, is a hormone made by the hypothalamus and stored in the posterior pituitary gland. It regulates the volume and osmolality of the urine by acting on the distal convoluted and collecting tubules and collecting ducts of the kidney. It also balances the amount of water in the blood by telling the kidneys how much water to conserve. Additionally, it increases the blood pressure by tightening the blood vessels. Tightening the blood means it is a vasoconstrictor. It is a vasoconstrictor. So these two mechanisms, these two actions are performed primarily by the ADH. How does aldosterone act to maintain the circulating volume? Aldosterone stimulates the reuptake of sodium by acting on the receptors at the junction between the distal convoluted tubule and galactic duct. So what aldosterone does, that it reabsorbs the sodium and secretes the potassium or hydrogen into the urine. Actions of renin, angiotensin aldosterone system, ROS system, function of angiotensin 2. Okay, so what happens actually, that there is a stimulus from the kidney, renin, when there is a hypovolemia. So kidney sends in the juxtaglomerular apparatus, it is secretes the renin, macula densa, and so okay, so renin is secreted by the kidney when there is a hypovolemia or shock. So this what happens, that renin is enzyme, it goes to the liver. In the liver there is a angiotensinogen 453. So the renin enzyme convert this angiotensinogen into angiotensin 1. Okay, and this angiotensin 1 goes into the okay, so in the lungs, only this enzyme is in the lung, angiotensin converting enzyme endothelium. So angiotensin converting enzyme endothelium of the lungs. So it is where it is in the lungs. Sorry. Okay, so this is in the lungs. So angiotensin 1 is converted into angiotensin 2 in the lungs. So it is in the lungs, and you can see the molecular weight is subsequently decreased. Here 453 and here 10 and here it is 8. So what happens that angiotensin 2 is the main Kiladi, or you can say the player. So what it does, it affects the cardiovascular system because it constrict the vessels. Plus, it also causes aldosterone secretion from the adrenal gland. So adrenal cortex acts on the adrenal cortex. So here we have the salt and water reabsorption, and here we have the salt and water reabsorption, and there we have vasoconstriction, and so it helps in the increase of the blood pressure. So it will increase the blood pressure. So they have explained it here that arteriolar constriction or arteriolar vasoconstriction and rise in systolic and diastolic blood pressure because of the contraction acts directly on the adrenal cortex to increase the secretion of aldosterone, direct effect on the renal tubules to increase the sodium reabsorption, and facilitation of the release of norepinephrine by direct action on the postganglionic sympathetic neurons in the adrenal medulla, and contraction of mesangial cells with resulting decrease in GFR. So mesangial cells are in Bowman capsule, so the contraction occurs and they tightens the filtration mechanism, and there is decreased GFR. Acts on the brain to decrease the sensitivity of the Bell reflex, and this potentiate the pressure effect of angiotensin 2. Acts on the brain to increase water intake and increase the secretion of vasopressin and SATH. It does not penetrate the blood-brain barrier, but it triggers these responses by acting on the circumventricular organs. Okay. So this is the renin-angiotensin aldosterone mechanism. Okay. And here we have post-operative oliguria, how to give fluid challenges. So these are the fluid challenges. So 250 ml bolus as fast as possible, 10 to 20 ml per kg for normotensive. If the patient is normotensive, okay, so patient is post-oliguric, means patient is oliguria. So if the patient is normotensive, give him 10 to 20 ml per kg. For example, for 70 kg, you will give him 700. So 10 ml per kg for one normotensive patient, and 5 to 10 ml per kg for hypertensive patient. Okay, and 40 ml per kg for hypotensive. If patient is hypertensive, then you have to give him 40 ml per kg, and how much time? And this 250 ml in 15 minutes, and 500 ml in 30 minutes. Fluid challenges can be given for 2 to 4 times. Why colloids are not given into post-operative patients? No evidence of Bennett or crystallites. Starches increase in motility in sepsis. Okay, so there is no evidence of benefit or crystallites, and there is starches increases motility in sepsis, more expensive, and risk of anaphylaxis. Why there is no benefit? Because in sepsis, why they increase motility? So whenever there is a stress condition or sepsis or stress, the permeability inflammation, this inflammatory condition, so there is increased permeability of the vessels. So what happens that the proteins usually leak into the interstitial space. So when you give colloids, so colloid will also diffuse into the interstitial space. So this will further increase the osmotic pressure in the interstitial space, and this will further sequester the fluid, so this can further deteriorate the condition as it does it in burns patient. So that is why we give crystallized, not colloids. So this is all about the this chapter.